This case has to do with a palpable lump. I'll go through the stem with you verbally, and then we'll go through the practice questions that are at the end of the module. I'll show you some examples of mammographic images, but I won't go through an approach to interpretation because that's well beyond what would be expected of someone in undergraduate medicine. So we have a 36-year-old female presenting to her family physician with a palpable lump in her left breast. It had been present for approximately 18 months and has been gradually getting larger. Recently, she noticed bloody nipple discharge on the left. Her family history is significant for a mother diagnosed with breast cancer at age 42 and a sister diagnosed at age 45. On observation, you notice subtle retraction of the left nipple in comparison to the right. Additionally, the skin of the left breast demonstrates a dimpled appearance. On palpation, you can appreciate a firm, fixed lump in the outer quadrant of the left breast that is non-tender to palpation. There is no appreciable axillary lymphadenopathy. Many of these features in the stem, outlined in bold, are highly concerning for malignancy. For instance, retraction of the nipple can be a sign of breast cancer, especially if there's a cancer underneath those tissues that's invading the surrounding parenchyma and tethering them and pulling them inward toward the breast. Breast edema is the cause of the dimpled skin appearance. Sometimes it's referred to as peau d'orange, which is a French term for orange peel skin, and that's when you have breast edema and the follicles of the breast get pulled inward and enveloped by the edematous tissue. Oftentimes, this can be caused by infectious processes like mastitis, but it can also be caused by inflammatory cancers. So this should be something that is on your radar and raise your suspicion for malignancy in this patient, especially when someone has 2 first-degree relatives diagnosed before the age of 50. So question 1 is, based on history and physical exam findings, what is the next most appropriate step? And for her, this patient is symptomatic, so referring her to a breast screening mammography program would not be the best course of action. By convention, screening programs are designed to screen asymptomatic people. And typically, when you present to a breast screening program, you can only get the craniocaudal and mediolateral oblique views of the mammogram, whereas if you refer for diagnostic mammography, they can have additional views plus or minus ultrasound for further assessment. You need a diagnostic workup in order to assign an appropriate BI-RADS score to what you're seeing on the images. And a BI-RADS score is a standardized lexicon that allows interprofessional communication. It allows the radiologist to convey to the clinical team the likelihood of the imaging findings representing a malignancy. So for instance, over here on the right, there is a hyperdense mass within the breast, and you notice the edges are radiating outward. We call this spiculated margins, and there are scattered foci of calcifications within there. So these findings are highly, highly concerning for malignancy, and this would actually be assigned a BI-RADS score of 5, which conveys a greater than 95% likelihood of imaging findings representing a cancer. Reassuring the patient because the lump is non-tender and there is no axillary lymphadenopathy is also incorrect. If a lump is firm, fixed in place, and non-tender, it's actually should raise your suspicion for a sinister pathology. If it was something like a benignly inflamed lymph node, it would be smooth, rubbery, and easily mobile underneath your fingertips. It's important to assess for axillary lymphadenopathy because it can give you information about the likelihood that the cancer has spread to that region, but no appreciable lymphadenopathy in this patient would not be a reason to not send them for a diagnostic workup. And lastly, sending for serum cancer markers and reassure if they are within normal limits is inappropriate. Sometimes cancer markers like CEA or CA15-3 can help monitor metastatic breast cancer, but having normal cancer markers in a patient with these findings would not preclude you from sending for a mammogram. Question 2. Based on the patient's family history, at what age should the patient have started breast imaging screening surveillance? In Canada, the recommendations for screening in people at no increased risk of cancer is to have a mammogram every 2 to 3 years between the ages of 50 and 74. However, because this patient has 2 first-degree relatives diagnosed with breast cancer, particularly before the age of 50, she would qualify into a high-risk screening group. And based on our guidelines in Canada, you would commence surveillance 5 to 10 years before the age that the relative was diagnosed. So because the mother was diagnosed at age 42 with cancer, the best answer would be D, age 32, because it's within 5 to 10 years before her diagnosis. What additional views may be associated with a diagnostic mammographic workup? The craniocaudal and mediolateral oblique will be present in all studies, whether they're diagnostic mammograms or screening mammograms. So the correct answer is spot compression and lateral views. A spot view, which is known as a spot compression view, is when you take a particular paddle and apply compression to a smaller area of tissue so that you can have better separation of overlying tissue structures, which can let you know whether something is truly a mass or whether it's something called summation artifact, which is when an overlap of normal breast parenchyma can give the appearance of a mass. It can also be used to better outline the borders of an abnormality found on imaging. A lateral view is also an additional view used in diagnostic workups, and it can either be mediolateral or lateromedial, and they're helpful in localizing different lesions that you can see. For instance, the mediolateral view is best for lesions located in the central or lateral breast, whereas the lateromedial view is best for evaluating medial lesions. This is an example of your standard mediolateral oblique and cranial caudal views here. So craniocaudal view means that the X-ray beam is passing from the cranial dimension down toward the caudal. And then in a mediolateral oblique, the X-ray tube and imaging detector will rotate into an oblique position and pass through the medial side toward the lateral side in an oblique fashion. And you can tell the difference because with a mediolateral oblique view, you can see a large portion of the pectoralis muscle. And in fact, this is important when assessing for image quality with these views. You would expect that the pectoralis muscle could be visible to about the level of the nipple line. And this is an example of a spot compression view. So here we have a standard mediolateral oblique mammogram, and the arrow is pointing to a possible mass or asymmetry that needs further evaluation. So the sonographer will take a smaller compression paddle and place it over the area of interest to reduce tissue overlap to better assess that area. And these spot compression views can be performed with magnification or without it. And the last question is, what is the clinical impact of having highly dense breasts on mammography? And the answer is A and B. It reduces the sensitivity of the examination and is a risk factor for the development of carcinoma on its own. In fact, some of the literature states that women with extremely dense breasts have approximately a 2-fold increased risk in developing cancer compared to women with breasts of average density. So here's an example on the left of a breast that is predominantly fatty. So when you see this dense mass, it's clearly identifiable from the surrounding tissue. But if you take this mass and put it over to this location in a patient with highly dense breasts, you could see how that could easily be obscured by overlying tissue. And this is why we say that having highly dense breasts reduces the sensitivity of the examination and may obscure small masses. And that concludes our case.